This is Dr. Zapchinsky. This presentation is an overview of abdominal pain, its patterns, how to take a focused history, how to do a good physical exam, developing differentials, and choosing diagnostic labs and appropriate imaging. Abdominal pain is the most common reason for visiting a primary care provider, urgent care, and ER. Surprisingly, about half of those that complain of abdominal pain leave without a definitive diagnosis. Why? Well, the abdomen houses so many organs: stomach, liver, gallbladder, pancreas, spleen, small and large intestines, appendix, kidneys, ureters, bladder, the aorta and vena cava, ovaries and uterus in women, that pain can be from anywhere. The cause of pain can be mechanical, from stretching or distension, such as constipation, kidney stones, which stretch the ureters, ectopic pregnancy, inflammatory gastroenteritis, peritonitis, appendicitis. It can even be from lower lobe pneumonia. Other causes can be vascular, such as abdominal aortic aneurysm, or ischemic, such as cardiac pain, especially in women. These are the types of abdominal pain. Visceral or organ pain tends to be dull and generalized. Organs are either hollow or solid. Hollow organs, such as the stomach, intestines, and ureters, are usually filled with liquid or gas that are moved forward by muscles. Pain in a hollow organ tends to be colicky or intermittent because muscles contract and relax. Examples are gallbladder and ureters. Stones in these organs produce colicky pain as muscles contract and relax around the stone. Distension of a hollow organ by gas or liquid can cause pain. Think of gas in the stomach or intestines, or an overfull bladder. In solid organs such as liver and kidneys, pain can be caused by the pressure of a malignancy, benign mass, cyst, or an accumulation of blood. Examples are portal hypertension of the liver or cystic kidneys. Parietal or somatic pain is caused by inflammation of the peritoneal membrane or peritoneum. Abdominal organs are wrapped by a thin layer of tissue called the peritoneal membrane. The abdominal cavity is lined by the peritoneal membrane. Parietal or somatic pain is typically sharp and localized. An example is peritonitis, which occurs in the middle stage of appendicitis when the inflamed appendix causes peritoneal inflammation. Burning pain is caused by irritation of gastric mucosa or esophageal mucosa by stomach contents. The typical pH of the stomach is 2 to 3. Examples are gastric ulcers and esophagitis from GERD. Referred pain, that's pain that radiates from one area to another. There's an excellent YouTube video on abdominal pain and its types, characteristics, and causes at this particular YouTube address. Some etiologies of abdominal pain have common patterns of radiation. Some examples are pyelonephritis, which is a kidney infection. The pain tends to move around the flank to the lateral part of the back. Nephrolithiasis, or kidney stone, often radiates to the groin. Hepatic and biliary pathologies, such as stones, radiate to the right shoulder. Pancreatitis and the pain from an abdominal aortic aneurysm can radiate straight back to the back. And appendicitis has a classic migratory pattern. We can talk about appendicitis here because its pattern of pain changes. In early appendicitis, the visceral pain, the organ pain, is periumbilical. It's vague and it's not associated with tenderness. A person may complain of soreness and move a hand around their middle abdomen when you ask them Where do you feel the pain? Why? Well, the appendix was formed in the midgut. This is why the pain begins in the middle of the abdomen or at the umbilicus, and it's vague. But as the appendicitis progresses to the middle stage, the appendix causes irritation of the overlying peritoneum. The pain then migrates to the right lower quadrant. It becomes localized, and there is significant tenderness. You'll see the rebound tenderness at that point. And then in the late stages of appendicitis, if appendicitis is not identified and treated, the appendix may actually perforate or rupture and cause generalized pain and signs of secondary peritonitis, such as fever, loss of bowel sounds, and abdominal rigidity. Pain differ. Well, we take a small detour here and we talk about embryonic development. Why is some pain dull and generalized and other pain is sharp and localized? Well, where the pain is felt has to do with how the organs in the abdomen are formed. Abdominal organisms arise from 3 embryonic layers early in gestation. Around the 3rd week, we start having the embryonic layers built. The liver, gallbladder, stomach, pancreas, and spleen all arise from the foregut, and eventually they move to the upper region of the abdomen. The ascending colon, transverse colon, and small colon, appendix, and cecum arrive from the midgut and move to the middle region, except the appendix and the cecum, which, although they're formed in the midgut, they go into the right lower abdomen. The sigmoid colon, descending colon, arise from the hindgut and move to the lower region of the abdomen. Along with this, spinal nerves also innervate these areas. How the brain interprets pain is affected by both embryonic development and the nerve innervation. Radiating pain is an example of nerve innervation and how it can seem kind of strange that I've got a kidney stone but my groin hurts, or I've got a gallstone but my right shoulder hurts. What process can we use for figuring out the source of abdominal pain? Well, we can use a framework, splitting the abdomen into 9 regions. The upper region has the right upper quadrant, epigastric, and left upper quadrant. The middle region is the right flank, the periumbilical area, and the left flank. And then the bottom region has the right lower quadrant, suprapubic area, which was once called hypogastric, and the left lower quadrant. The simplest principle to use is to think about what organs underlie each region. This is where knowing your anatomy is very important. Dr. William Osler, a 20th century physician, was quoted as saying, "Listen to your patient. He is telling you the diagnosis." That means that the more questions you can ask and the more you can get the patient to tell you, the better you will have a differential and eventually the diagnosis. So the evaluation of abdominal pain begins with a thorough history. We start with the chief complaint, and the provider develops a history of the present illness that begins with onset. When did the pain come on? Did it come on suddenly, abruptly? One minute the patient was fine, the next minute they were bent over in excruciating pain. An extremely abrupt, acute onset of persistent, intense abdominal pain is never a good sign. It's a red flag that you need to send that person on for emergent evaluation. Then we will ask, where is the pain? And if the patient can point with one finger, that's going to give you a clue that the pain is localized. And if they cannot, if they have to move their hand around the abdomen, then that means the pain is more generalized. And they may even be able to point the pattern of radiation. The pain starts in my middle upper abdomen and it moves to my right shoulder. So these are important clues to the type of pain. What is the duration of the pain? This is frequency. Is this something that's continuous or is it episodic? Episodic pain in the upper region of the abdomen may be a clue to biliary colic, gallbladder problems, or GERD or gastroparesis. A continuous pain in the lower region is a clue to, say, middle stage appendicitis. Ask them to characterize the pain for you. What does it feel like? Is it stabbing, burning, gnawing, sharp, dull? And get them to rate the pain on a scale from 0 to 10, where 0 is no pain and 10 is such excruciating pain that they cannot abide by it. Then ask what things aggravate and help the pain. What makes the pain worse? Is the pain related to food? If food makes it worse, and these are clues to upper GI, pancreas, and gallbladder involvement. If food or antacids make the pain better, this is a clue to duodenal ulcers or GERD. And finally, what are the associated symptoms? What else did they come in with? Is there nausea and vomiting? How much vomiting? What's the color? What's the consistency? Have they vomited so often that now they are dry heaving? Is there fever? How much fever? Have they had fever for a while or just today when they came in and you checked it? Is there dysuria? Is there hematuria? Are they having constipation or are they not passing gas or stool at all? So these are some of the associated symptoms. And finally, if gastroenteritis is suspected, ask if they've been around somebody else who has been ill. Once the history of the present illness is developed, you can move on to these other histories. These are all subjective. Subjective means that the patient is asked and they answer. It's anything the person says. So past medical history, these are diagnoses such as hypertension, hiatal hernia, anxiety, depression, cardiovascular disease, cancers. This can help the provider determine risk factors. Ask about abdominal surgeries. Do you have your gallbladder? Do you have your uterus, ovaries, appendix? Have you had weight loss surgery? Any cancer surgeries? You want to know what kind of abdominal surgeries they've had. Get a GYN history if it's appropriate. Assume that all women of childbearing age are pregnant until proven otherwise. Is there a history of miscarriage or ectopic pregnancies which can tend to repeat? What about medications? Get a list of their medications, including anything they're taking over the counter. There are tons of over-the-counter supplements that people take, and they're not just vitamins, herbals, different types of thyroid medications or hormones, that type of thing. Find out what they're taking. Ask specifically, what do you take this for? How much do you take? And how often do you take it? Do that for every medicine. And now this is presuming that the patient is not in such severe pain that they can answer these questions. Get a good sexual history if you suspect an STI or PID, pelvic inflammatory disease. Ask about substance abuse, especially alcohol and marijuana. Marijuana can cause all kinds of nausea and vomiting in patients. Get a travel history. Have they been out of the country? Where did they go? Did they get vaccinations prior to going? Has there been any exposure, such as to food or water that may have been contaminated? Church picnics and buffets are notorious for gastritis related to contamination. Once you've conducted a good, focused, thorough history, you're going to do the physical exam. Focus on the vital signs. Are they within normal parameters for a person of this age? Is there elevated blood pressure or low blood pressure? Is there temperature? Are they tachycardic? Are they tachypnic? What is their general appearance? How do they look? Are they comfortable or are they not able to sit still? They're writhing in pain or they're afraid to move because they're in such pain. Your general observation is going to tell you a lot about the condition of the patient. Your focus is going to be on the abdominal exam. So you're going to get the patient on the exam table and undress so that you can adequately inspect the abdomen. So remove any obstacles so that you have a clear view. You're going to look for, you're going to start with inspection and look at the contour of the abdomen. Is there distension? Is there discoloration anywhere? Can you see old scars? Is there guarding? When you come near them, do their muscles tense up? This is an unconscious phenomenon. The abdominal muscles contract to protect the organs underneath, and it's a sign of peritoneal inflammation. Then you're going to auscultate and listen for the bowel sounds in all quadrants and in between. Describe the bowel sounds. Are they normoactive or are they hyperactive? Maybe you don't hear any bowel sounds. Is there a pattern to the bowel sounds? Do you hear tinkling, high-pitched bowel sounds and then no bowel sounds? That could be an indicator of an obstruction. Then you're going to palpate the abdomen, beginning with the non-affected area and as gentle as possible. Gently palpate and then check for rebound tenderness. That's where you push your fingertips down into the area and quickly release. And rebound tenderness, positive rebound tenderness, is pretty diagnostic for some sort of peritoneal inflammation. If reproductive involvement is suspected, a GYN exam needs to be done. Next, you're going to do a cardio and pulmonary exam, doing a good assessment of the heart for rhythm, rate, for any murmurs. You're going to listen to the lungs. You're going to look for respiratory effort. Remember, some pneumonias can have referred pain into the abdomen. A rectal exam is not always performed, but depending on what you think the cause may be, you can do a rectal exam if anal, rectal, or prostatic disease is suspected. And one of the reasons we do this is if we're looking for occult blood in the stools. Once you have done a full history and exam, you're going to begin to figure out the differentials. Differentials are, what do I think this problem could be? And that is based on the chief complaint, the history of the present illness, all the risk factors that you got from looking at the history, and your physical exam. And there are a multitude of things that can occur in the abdomen. And this is a picture that you can take a picture of this and put it in your phone for yourself, of differentials by region. Notice that the upper right quadrant is missing. That's on the next slide. This is a list of the types of differentials for right upper quadrant pain that involve the liver and the gallbladder and the lungs. Notice that there can be infectious or non-infectious reasons. Once you have a list of differentials, then you can begin to decide which labs are appropriate for your patient. The CBC is helpful for bleeding and anemia. The hemoglobin and hematocrit, if they're low, can indicate bleeding. The MCV, which is the mean corpuscular volume, is helpful for determining the type of anemia, whether iron deficiency or vitamin B anemia. The MCV is the size of the red blood cell as measured under the microscope. Normally the size is 80 to 100 FLs. If it's less than 80, that can indicate iron deficiency. When it's greater than 100, that can indicate a vitamin B deficiency. The total white blood cell count and neutrophils are helpful for determining infection. A normal white blood count is 5 to 10,000. Neutrophils make up about 75% of white blood cells, and their normal levels are 2 to 7,000. Higher levels can indicate an active infection, and these are the white blood cells that increase first in an infection. Liver function tests such as the AST and ALT are very helpful for looking at acute hepatitis or problems that come from liver disease from hyperlipidemia. An alkaline phosphatase is very helpful in gallbladder disease. Bilirubin is helpful for biliary obstruction, and a lipase is helpful for pancreatitis. You can do a metabolic panel, and that will give you an idea of how the electrolytes are looking. Do a urine HCG pregnancy test for any woman of childbearing age who comes in with abdominal pain. You don't want to miss an ectopic pregnancy. You can do a lactate if bowel ischemia is suspected, although I imagine that if you suspect bowel ischemia, you're going to send that person on to the ER. If the person has cardiovascular risks, you may want to do troponins or an EKG. Heart pain is one that will radiate, and it can radiate to the abdomen. You can do a urinalysis and a culture and sensitivity if you suspect urinary symptoms as well. If you're dealing with acute abdominal pain, you will need to do some imaging. Now, CT scans are the standard for acute pain, such as appendicitis, kidney stones, or infections such as colitis, diverticulitis, or tumors and vascular conditions, and especially for trauma. A CT is highly detailed cross-sectional view of all the organs and vascular structures and bones. The pros, it's fast and accurate. The cons, radiation exposure. It can be many times higher than a standard X-ray or a plain film, depending on the body part that you're looking at. For instance, the pelvic organs are much more vulnerable to radiation exposure than, say, the head or the neck. An ultrasound is best when you're looking for problems in the right upper quadrant, such as gallstones. It's also helpful for pelvic pain. It reveals real-time imaging of soft tissues, fluid collections, and can show you blood flow. The pros, no radiation, and it's typically portable. The cons, often the results and the imaging can be limited by the person's body habitus, such as obesity, and by bowel gas. An MRI is best for detailed imaging of the pancreas, liver, biliary system, or when you're avoiding radiation, such as in children and in pregnancy. It will reveal soft tissue contrast and detailed evaluation of soft tissues and organs. It's a good way to look at these. Pros, no radiation and lots of detail. The cons, it takes a while to get the results, takes a while to do the test, and it can be less available. Plain films or X-rays are best for initial quick assessment for things such as constipation or ingested objects, providing they're radiopaque. In other words, they'll show up on an X-ray. Or if you're looking for a bowel obstruction, which may appear as dilated bowel loops, or a perforation in which you can see free air in the abdomen. The X-ray will reveal general overview of the abdomen. Do not forget that sometimes you need a chest X-ray, as some pneumonia pain can radiate to the upper abdomen. The pros for using X-ray, low radiation, and this is an important consideration. And the cons, you can miss subtle or complex pathologies. Red flags for abdominal pain. Red flags include the sudden, abrupt onset of acute pain with guarding, tenderness, and intense pain, accompanying tachycardia, tachypnea, hyper or hypotension, hematemesis, bleeding from the rectum. These are all red flags that mean you need to refer the patient. And let me tell you that in this case, referral, we often think of as a registered nurse that we're going to make an appointment for the patient to go and see somebody. In this case, Referral means we're going to send them emergently right now by ambulance, or if they're not that sick, we're going to get them to go to the emergency department to be further evaluated. So don't get caught up in referral meaning making an appointment.